I wanted to go over some of the duties of an in-home aide, and I'm going to touch on several different areas because there's so many moving parts when you start to think about what the aide's duties are, if they're qualified to do it, if they need special training. So I'm going to try to merge those things together for us today so that we will be able to, it's just quite a few things you need to consider. So that's what I'm going to do today, because I do get a lot of questions about this. And if you miss any part of it, then you can sort of get off track. So the first thing I'm going to do is I'm going to talk about in-home aid duties. What you see on this screen is directly from the rules and regulations, directly from there. So I just thought I would give it to you that way so that you can remain in compliance. So the things that an aide may do, they can help with prescribed exercises that the client that have been taught by the healthcare practitioner. So that could be that the nurse may teach them how to do range of motion or whatever, but often it is the physical therapist that may be coming in to see that client, or the client knows what their exercises are. So they can help kind of assist with those exercises. They can provide or assist with ADLs, and I'm going to tell you exactly what the ADLs are that are under these rules and regulations in a later slide. Note, they can assist with self-administered administration of medications. That means when I was running my agency, what that meant to my aides is that you do not open that, you can open the prescription bottle for the client, but you do not pour any pills out. You do not put your hands in that prescription bottle. The client must be able to get those meds out. And the best way to do it, if they do have deficiencies in that area, is to have a prescription, one of those containers where you put the meds in there and they know what to take at certain times or on certain days. So I really went over that with my clients when I was admitting them. I would say my aides can get the water and hand them the bottle or whatever, but they do not know anything about medication, so do not ask them to assist with that. And then they can perform incidental IADLs, and that's things like making the bed, cooking, doing the dishes, cleaning up the area where the client is. They can do those types of things. And then they should record and report any changes in the client's condition to the healthcare practitioner. If you're an in-home aid agency, that would be your RN. If you only do companion care, that will be your service supervisor. But whoever their manager is, if they see changes in that client's condition, they need to be reporting it. And I often found that when I went to a client's house, I would always ask the aide, has their condition changed? And they always knew. They were really good because they work with that client every day. They knew that yesterday she could do this, or she spoke to me that way, and today it's different. So I would really trust their judgment. When they told me that something was going on with that client, I did not question them because I knew they knew a whole lot more about that client than I did. And most of the time, more than the family. The companion sitter duties. Companion sitter is an individual who spends time with or provides non-hands-on services to the client. So I always say to everyone, the companion sitter does not touch the client. You're there for like a companion, just to be with them. Of course, you're going to make sure they're safe, but you're not helping them with bathing and dressing. And then keep in mind, when we get these clients initially, they come to us, they may be in one condition, but many times and most often their condition may start to decline, and then they're no longer a companion sitter client. Just from a business standpoint, I tell my clients, if you can go into an in-home aid agency, this is from a business person standpoint, do the in-home aid, because you can do a companion sitter client as well as an in-home aid, and you get to keep that client during that time. But if you're a companion sitter agency, if you're going to follow the rules, when that client gets to the point where they do need you to help them get dressed, they are needing more care, Then if you only have companion sitter, you're operating out of your scope of service. And so keep that in mind. You do not want to do that because that's a lower level of care. So just keep that in mind. And some of the non-hands-on services are right here on the screen: home management tasks, shopping, meal prep, transportation, socialization, medication reminders, things where you do not have to touch that client or they don't have a need for that. And respite care is where you come in, the client, the caregiver has to do something and they need someone to come in and take care of the person to relieve the caregiver. Many times I saw that my agency would help with respite care because we did CAP, which is the Community Alternatives Program under Medicaid. And those clients get paid respite care hours. So sometimes we would get a call and they would say, Mrs. Jones' daughter has to go away for the weekend. Do you have someone to provide respite care? It may even be a client that you're already servicing 5 days a week, but they need respite. So this is another part of this. There's a lot of moving parts. All of your in-home aides, caregivers, they must have their skills validated. And the mode of validation is this supposed to be observed by the RN, because we're talking in-home aid right now. They should observe and make sure that that aide knows how to assist with ambulation and bed transfers, that they know how to assist with a shower or a bath, assist with toileting, assist with getting dressed, and assist with eating. Now that would mean that actually helping them to put the food, in their mouth or whatever, but helping them with eating and of course preparing the food, and also assist with incontinence needs. Now that's toileting and incontinence. I guess toileting would be if they can still go to the bathroom, but if they're incontinent, of course, you would have to change them. And so keep in mind, this is way outside the scope of companion sitter. This is in-home aides. And while I'm on this, I will just mention an aide that is not on the nurse aid registry can perform these skills. You just have to validate that they know how to do it and that the RN has seen them do it or taught them, and she has checked them off. So they don't have to be on the registry. I'm going to show you later in these slides when they do have to be on the registry. So you can have in-home aides in your agency, some that are on the registry and others that are not, but all of them have to have their skills validated. So going to these are the activities of daily living that your rules and regulations recognize. It's 5 of them. Mobility, that's getting up, getting around, eating, we just talked about that, bathing and dressing, and toileting. Now in this instance, toileting would include incontinence needs. So these are the ADLs that you can perform as an agency for that client. It's all 5 of these. And with each one of these, you're going to have to indicate, your nurse or service supervisor is going to have to indicate in her plan of care what level of assistance they need for mobility, eating, bathing, dressing, toileting. Your care plan should address that directly, each one of those. So that is definitely something that they look at. And just the reason that they do that is because it determines what level of in-home aid you can assign to that client. So you have the 5 ADLs that I just showed you, and now you have 5 levels of assistance. Independent means they do not need really any assistance. That would almost be a companion client, but it would be, they don't need any assistance with eating. This would apply to each one of those. Then supervision, that means you're going to monitor them. But I always felt that if I had an aide in the home, no matter what level they are, it's supervision, because you would not be there if you weren't paying attention to that client and seeing if they needed something and taking care of it to keep them safe. And then limited assistance would be, say if it's taking a bath, do they need help taking a bath less than 50% of the time? That means you're helping them a little bit, but they're doing most of it themselves. That would be limited assistance. And then extensive assistance would be they need help more than half the time taking that bath. That would probably be if it was a sponge bath, you're putting the soap on the cloth and you're wringing it out and you're helping them, and maybe they'll wash their face, but they need a little bit more assistance, quite a bit more extensive. So just keep that in mind. And of course, with totally dependent, that means they can't do it at all. This would probably be, if it was eating, that would mean you're picking up the fork and putting the food into their mouth. That would, if it was bathing and they were totally dependent, it may be a bed bath. So when you get below limited, that's when you're looking at an aid that would be on the nurse aid registry. And so this came right out of the rules and regulations here, you all. So I put it up here so you can see when it gets to an extensive level of assistance, this is when you need to go to an aid that's on the North Carolina Nurse Aid Registry. It means that the client is totally dependent or requires hands-on assistance more than half the time. I just mentioned that. I said 50%, that's half, while performing an activity that meets one of the following criteria. So we got other criteria. There's a lot of moving parts. Number one, aid requires extensive assistance in 2 activities of daily living. Now, I showed you the ADLs, bathing, dressing, eating, mobility, and toileting. So if they need extensive assistance in more than 2, that means they need help more than 50% of the time, then you're at the point where you need an aid that's on the nurse aid registry. And this changes. They come in one way and then it changes, or they get sicker, they may fall. So you have to watch this. Your nurse has to watch this on her supervisory visits, okay? And then the next one is they need an in-home aide to perform at least one task at a nurse aid 2 level. Now, there are some tasks, and we haven't talked about this before, maybe I'll do it in another meeting, but there are some nurse aid 2 level tasks that can be done in an in-home aid agency. An in-home aid agency can choose, I think it's 3 tasks, and I'm just gonna have to verify this, that are nurse aid 2 level tasks that they can teach within their agency. They have to let DHSR know, and that would be something like catheter, or there's just several things that are nurse aid 2 level tasks that your agency can choose. But if that client needs at least one of those that your aide needs to perform, one of them I think is a tube feeding also, but I'll get into this for you all later. Then that means they need an aide that's on the nurse aid registry, because then you're asking a nurse aid 1 to do something for a nurse aid 2 level. So you know that you would not use a person that's not on the registry at all. And this next one is they require extensive assistance in more than 1 ADL, and they have a cognitive impairment. So that would be your dementia or your cognitively impaired clients. That would be an additional consideration. If you have someone that's cognitively impaired, then they start to lose their ability to dress properly or take a bath and all of that. So watch those that have a cognitive impairment very closely. Once again, nurses, pay close attention to the status changes in your client. I know you're going out there every 90 days, but make sure you're in good communication with your aides, because you want them to constantly let you know when something has changed, so that you may have to go back out there sooner. So however you're having your aides communicate electronically, are they writing something on their care notes? Pay attention to that and make sure that you respond to it. And that's basically what I had today. I know it's a lot, but it's a lot that you all have to consider when you make assignments and when you make sure your clients are cared for according to your rules and regulations. And I always like to let you all know that I am very happy to present this information to you every month. However, I like for you to know that before you make a change to anything in your agency, that you check directly with the agency that governs you. That would be DHSR. or if it's the labor board, whomever it is, you check with them before you make changes in your agency to be sure that you're doing things properly and not just based on the information that I gave you. And if you need information from me, I'm always happy to give you additional information, and you all know how to get in touch with me. But I just really want to be sure that you do things according to your rules and regulations. And you know that as an agency, you have to follow all state and federal laws as well. I just wanted to mention that. So that was basically what I had to cover today. I know it's a lot and it can be confusing. So I am open for questions right now, if anyone has any. Any questions?
Patty, how you doing?
All right.
My question is, I know we talked about this before. When the client is asking for our aides to do more than just their duties, how do you handle those type of situations when they're set for one plan of care, but then they get there and the wife or the husband is asking them to do more or care for more than one client?
Yes. Okay. So let me just address that. First of all, when your nurses go in to do the assessment, make sure that they cover those things to be sure that client understands that. But it's going to happen, Karima. They're going to push as some of them will push as or add as many things as they can, and think that the aide may not say anything. So that's when you've got to step up as a boss. You've got to step up as a boss and a manager, and you have to be fair with the client and the aide. And you have to make sure that that client understands this is not part of the care plan. We are here to care for Mrs. Jones. Mr. Jones is not on here. Now, if Mr. Jones needs care, we can add an additional 2 hours or whatever it is we need to do, or we can send another aide. But you're going to have to step up and make those things happen. And those are difficult situations, because one day they come in and the person just says, well, can you make my husband a cup of coffee? The next day they're fixing his food. His clothes are in the wash. Trust me, I've been there. So you have to really address that. That's when you become a boss of an agency or a business owner, and you have to address it so that your clients aren't offended, and you have to protect your aides. Because that's one thing you want to be known for. You want to be known for standing up for your aides when you need to.
And when these type of things happen, can we do things like you said, charge them additional hours, or do we need to get a plan of care for both clients? Or is it okay to just say, okay, since she's there and she's not doing any hands-on care, is it okay we just charge them additional, say, okay, well, we'll charge additional $10 an hour to assist in these duties for your husband or your wife?
Okay, so you can do that, but keep in mind, if you take Mr. Jones on as a client, admit him fully.
Okay.
Do a full admission packet on him. And if he only needs 2 hours, you put that on him. Don't just slide him in, because he is another name at whatever. Okay. So make sure that everybody you all that you're providing care for, you have a full admission packet on them. And now some of this stuff is very easy to do when nothing happens. But what if Mr. Jones falls and your aide was caring for him, and it gets back to whatever, your insurance or DHSR, and they're like, this man wasn't even your client. You never admitted him. You didn't write a care plan. So be careful of that. It's going to be an extra little bit of work for you, but do everything legally in that way.
Okay. All right. Thank you.
Mm-hmm. Other questions? Any other questions? Okay, well, I don't have anything else today. I hope that everyone is doing well, and I will get this recording up on our YouTube channel in a few days. So you all know where to look to find that. Tim, did you have a question or comment today? You're on mute. You're on mute, Tim.
I'm sorry. I just want to know if you could put your contact information, your email in the chat. I saw it come up on the slide.
I can. Tim, did you say something? You're on mute, Tim.
Yeah, I just wanted to just say hi. You know, I wanted to log in, but I got on late today. Unfortunately, I had an interruption, but I'll try to be more on time next time.
Okay, and we'll put the recording up and we'll let you know.
Okay, good.
You do that. Anyone else with a question?
Yes, this is Tanya.
Yes.
This is more of an office related, administrative related question. Is that okay?
Yes, it is. Any question is okay.
Okay, so do you have to have a paper copy? What I've been doing recently is electronically saving the aides documents in like their own folder on my computer. Do I have to have them printed if, for state purposes, or is it okay to, because I know they have to have access to a computer if they come out anyway. So do we need to have a printed copy?
I wouldn't, if you have them and you know that you're going to keep track of them electronically, I would print them when the state comes out.
Okay.
Yeah, if you know that you're going to keep them in a space where you can get to it. But it might be good, Tanya, for you to back those up on a thumb drive or something.
Yes.
Because you know how these computers, I know when I was in business, I went through 3 or 4 computers. And there was one time that I had a gentleman doing my computer work, and there was one time one of the computers went down, and when he got inside of it, he couldn't get to the hard drive.
Oh, wow.
So back up on a thumb drive or something like that, and keep it so that if they ask for it, you need it, because you need to keep your records for at least 5 years.
Yes.
So look in your rules and regulations and look at that. But if you feel comfortable, I would not print it out unless they ask for it. And they may even be comfortable looking at it on the screen.
Okay. All right. Thank you.
Anyone else?
Miss Patty, I do have another question.
Okay.
I know for Medicare and for us to accept Medicare, we have to have a nurse. But when we don't have a nurse, can we still accept our private pay clients?
You're talking Medicaid, Karima, not Medicare. No one on this line is doing Medicare unless it's maybe Jennifer, because she's in a different agency, but you're talking Medicaid. So your question was, you don't have a nurse, but you have a private client that qualifies for really in-home aid services, right?
Yes, ma'am.
No, that's what I just went through. I was telling you that if that client needed bathing and dressing and you're a companion care agency, no, because you have a license you're in the state of North Carolina, correct?
No, I'm in South Carolina, but our rules are similar.
Okay, well, if you go by your rules and regulations, but if you were in North Carolina, we're all licensed here, whether we're private pay or whatever, we're all licensed. You would not legally be able to have that client. Now, South Carolina may be different, so double check.
Okay. Thank you.
Any other questions? It doesn't matter what it's about.
I have a question.
Okay.
Yes, so I'm in the process of working on my personnel records. And of course, right now, I don't have any employees. So as me being that director and supervisor, can I be an employee until I get some later on, just to get through the licensing process?
You can, Davita, but that means you would be the agency director, the service supervisor, and the caregiver, right?
Yes. Yeah, I know.
You can do that, but I personally feel like it looks a little bit strange. And so try to find at least one person that you can put forth as your caregiver in the initial licensing. Now, later on, once you get your license, you can sign the caregivers or job description, and of course you can work with clients. But for the licensure, see, the reason they ask you for those personnel records on licensure is because they want to be sure, especially on the caregiver, they want to be sure that you know how to hire someone and that you have good, solid procedures on how to get that person into the agency properly. So if it's you, that really doesn't tell them, it tells them you know how to do it, but there's something else to deal with when you find a person and you go, do you have your TB test? Sign off for hepatitis B. Did you take your orientation? So they are trying to see that you know how to do that. So when they give you that license to put on the wall, they know that you're going to be having good procedures and good hiring practices.
I see what you mean. Okay, so in another question I have somebody who's interested, but they only want to volunteer. So how would I need another set of policy and procedures, or can I just move on right ahead and put them on as an employee?
You would need to hire them as an employee. And so they're saying they don't want to get paid. Is that what you're saying?
Right. I know it's strange.
So, for your purpose, Davita, hire them, do every piece of paperwork. Because even if they went out and they were a volunteer, they're doing things for your agency under your liability insurance. They're doing all of that. And so you need to make sure that you have checked their background, that you did everything you needed to do, because you're sending them into someone's home. And that's the reason that you go through that full process. So you treat them as a straight up employee. And if they don't want to get paid, then that's something that you deal with them.
Okay, so I'm sorry, is there another set of paperwork since they are a volunteer?
No.
No.
Give everyone the same paperwork, because they need to be screened for TB. You need to check their hepatitis B status. They need to go through all of the orientation. They need to do all of that because they're going to go into someone's home representing your agency, and whatever they do, you're going to be liable for it.
Okay, I see. Okay, sounds good. Thank you.
Mm-hmm.
Ms. Patty, thank you for saying that. Ms. Davita, I just want to second, this is Kate from Illinois. I want to second what Ms. Patty said. She's correct, because I did my licensing in Illinois, and I used all volunteers to do the licensing. Like, I got one person who I didn't have to pay, and but I have to do everything that Ms. Patty said. Like, I have to do her, encourage her to get her chest X-ray or TB or whatever. With my policy, I had to do everything. The only thing I didn't pay her was she's my relation. So she's right. I just want to share that with you if he's going to help you. And, I got my license. So.
Oh, wonderful.
Right.
Thank you so much for that. Thank you.
Yes, someone, RXH iPhone, has their hand up. Would you like to ask a question?
Yes, Miss Patty, this is Randez Haddon with Health First Pros.
Okay.
Thanks for allowing me to join the meetup today. We're a relatively new home healthcare agency and based in Youngsville. And we recently, I do most of the administrative and background, the administrative back end stuff of the agency. My co-owner is the RN. She's not able to join today. But my question concerns Medicaid. We worked through the process and we finally got approved for Medicaid, except Medicaid patients in North Carolina. But so far we've gotten none. And it's been a few months, and we've reached out to the MCOs, I think it's Liberty. I don't have them in front of me off the top of my head. Is there any, is there something we're not doing? Is there any key to getting the Medicaid referrals?
Okay, so did you all sign up in QI report? Do you know what I'm speaking of?
No, I don't.
Okay, so there's something called QI report, and you need to go in there and sign up to let them know my agency name is such and such, and we take Medicaid, and therefore you will be on the list in case a client comes up that may choose your agency. That's kind of how it's supposed to be, or they can assign a client to you. But it's called QI report. There's quite a bit of information, and there's a really good website for North Carolina PCS Medicaid, it is nc-pcs.com. It is under Liberty and it tells you everything. They even have a nice video on there that explains everything to you. So I really think that you need to do that, because right now, even though you're qualified for Medicaid, if you haven't signed up in QI report, they may not even know that you're able to be referred to.
Okay. Yeah, I'll check that. I don't think that my partner has done that just yet. Also, I think she'd like to speak to you. So is it okay if I have her reach out to you?
Sure, that'll be fine.
Okay. Thank you so much.
Thank you.
Hey, Patty. This
Yes.
is Crystal. You mentioned TB tests, and I would love some clarification on I know at Hire, they have to have a cleared TB result within the past year. Annually, we actually don't need to, and this is in North Carolina, we actually don't need to get a cleared TB. We just need to do a risk assessment by the nurse. Is that correct?
That is correct. That is correct.
So if as these aides move between agencies, I mean, they're likely, if we have to have a cleared TB result within the last year when we hire them, and they move between agencies so often, they're probably getting a TB test about every year anyway. But are we allowed to bring somebody on who has a TB result that is older than a year if we do a risk assessment at Hire?
No, I wouldn't. You can do whatever you want, but I think everyone that you bring in, you want to be sure that that TB test is within that 12-month period when you bring them in.
Okay. All right. And then just a risk assessment.
That's right. That's right. Because see, you're that check. You know, when they come in, if it's expired, then you tell them to go get a new one or you don't bring them in. And as I just said to Crystal, you can do whatever you want. But if you ever get audited or surveyed, that's when it becomes a problem. And TB tests can really be an issue because sometimes people overlook those. But when they come to you, you make sure everything is straight up and down when you accept them. And then, you know, whatever happens after that, you're not responsible for.
Yeah. Thank you.
Any other questions?
Hi, I have a question. This is Keyshawn with Auntie and Home Care. I just have a question about what others are doing as far as private pay clients. I'm actually trying to find the best idea to obtain to get private pay. Now, once others receive private pay, and I'm mostly talking about insurance private pay. Is it something that you need to verify with their insurance to make sure that they actually can pay for the services?
Well, the way I did that is when I accepted a private pay client and you tell them what the rate is, that client actually owes you that money. Now, if they have long-term care insurance, is what we're talking about now, you all, that's what pays for this level of service.
Yes.
When my clients had long-term care insurance, they have the option to either have the insurance company send the money to them, or the insurance company will send the money to you with additional paperwork. Because each long-term care insurance company has certain things that they want from you. They want to see the care notes, they want to see your license with the state. Some of them want to know that you're insured. And then they let you know whenever you get ready to submit your bill, you send it here and we'll pay. There is something that most companies have that's called an assignment of benefit. The client has the ability to sign that with you, as your agency. And it means that when you submit all the things to the insurance company that they want in order to pay that bill, they can send the check directly to you and leave the client out of it. One of my clients had a long-term care policy. They were with another agency and they were allowing the money to be sent to the client. And she was trying to take care of her husband. It was just too much on her. So when we came in, I let her know that we could get her out of the loop, that we would have the checks come to us. And she was really happy with that. It was a relief for her. She didn't have to wait to get the check, wait for it to go on in the bank and then write a check. And plus for you as a business person, it's better because these insurance companies take about 30 days to pay. And if all of that has to go on, it makes it even longer. So when you sign up a private pay, whether it's coming from the insurance company or out of their bank, you are really just contracting with them to pay you that rate at whatever amount of time. And of course, if it's an insurance company involved, you want to do everything you need to do to be sure they get reimbursed or that you get reimbursed. Did that help?
Yes, it did. Thank you.
All right. Any other questions?
I have one more quick question.
Okay.
So I'm licensed and done everything as far as NC tracks and everything. Now I've done the training with SendData. I am having some issues receiving the welcome kit, and what SendData, which is the EVV system for Medicaid, they came back and told me that they could not find the MPI. I verified all of that. So they're saying that I should be on some kind of national provider network for, I'm assuming it's Medicaid. Are you familiar with that?
So are these Medicaid clients?
Yes, I have no clients yet. I'm just setting up everything.
Have you been approved for Medicaid?
Yes.
So if you wouldn't have gotten approved for Medicaid if you didn't have an NPI.
Okay.
You have an NPI. It's a 10-digit number.
I do. I got a national provider identification. I think that's what they call it. Yep.
So I'm not sure what SendData is asking you for because you have a valid NPI because you had to use it to get qualified for Medicaid. So they may be asking you for something else. I'm just not sure. I've not really dealt with them. I know that they provide free EVV for Medicaid providers in North Carolina, but that is the question I have not heard before.
Okay. Thank you.
All right. Any other questions? Okay. All right. Well, I want to thank you all for coming today. And as I said, we recorded everything. We'll get it up on our YouTube channel. And we hope that you all will have a good weekend and a good rest of the month. You all know how to get in touch with me because if you're on this call, then you have my email address. And at the bottom of my email, I also have a line that takes you to the videos for every month. It says monthly meeting videos. If you click that button, you go to our YouTube channel. But if you need to get in touch with me, I put my email in the chat and my phone number. So feel free to call me and best of luck to all of you. And we hope we'll see you next month. We'll let you know when we're ready to do this meeting. It is the second Friday of each month. And thank you all for coming.
Thank you.
Bye-bye.